Hello, dear friends. Welcome to yet another webinar organized by Thalassemia International Federation, this time in the context of its Thal platform, that is the educational platform for our patients all over the world. So I welcome our participants from different parts of the world and allow me to give a special welcome to our distinguished guests who are going to give us their light in the area of liver disease in thalassemia. Professor Dusheiko, Geoffrey Dusheiko, who has been a long-term invaluable collaborator of Thalassemia International Federation, and of course with considerable experience in the area of liver disease in this particular group of patients in thalassemia, having extensive experience in the UK. And Professor Koskinas from Greece with an equally high level of expertise in the area, and in particular viral hepatitis, and with considerable knowledge and experience in the area of thalassemia. Dear friends, dear Professor Dusheiko, dear Professor Koskinas, I would like to express on behalf of the Board of Directors of Thalassemia International Federation our gratefulness and our deep appreciation for your invaluable work. And the first presentation is by Professor Dusheiko, liver disease in hemoglobinopathies, and in particular thalassemia, past, current, and present. This kind of presentations have been provided also for our healthcare professionals, our medical experts in the previous weeks. And all the series of webinars that will follow from this one as a first webinar onwards until the end of October will be particularly focused on the education of our patients. Professor Dusheiko, once again, our thanks, and the floor is yours.
Thank you very much, Dr. Eleftherio. I'm going to, in the next 20 minutes, try and just condense down some of the aspects of liver disease in thalassemia. And I hope that I can paint a hopeful picture with new therapies for specific diseases, as you'll hear, but also new therapies and new, better monitoring in liver disease. So thalassemia and liver disease, I think many of the patients and persons with thalassemia listening to this will be very familiar. They know that multiple blood transfusions at an early age can give chronic viral hepatitis and iron deposition, and indeed they know this better than their physicians. The main causes of liver disease in thalassemia remain iron overload, the hepatotrophic viruses, particularly those that cause persistent hepatitis B, particularly and hepatitis C, depending upon the geographical region. I'm not entirely clear how much non-alcoholic steatohepatitis and non-alcoholic fatty liver disease is being reported worldwide in patients with thalassemia, but clearly this is a growing problem that is actually in Europe surpassing the problem of hepatitis C. And of course, alcohol abuse may affect the liver. All of these may act injuriously upon the liver and may act together. And we always tell patients that alcohol and hepatitis C is a bad combination. For example, hepatitis C and NASH is also a bad combination, and we need to address both. In patients with sickle cell, there are distinct forms of sickle cell hepatopathy, which I won't go into much detail today, but they can be a little complicated for patients and physicians. So this is a picture of the human liver anatomy. I think many of you will know that the liver is situated on the right side. The liver is the biggest single organ in the body. Unlike the kidneys, we only have one liver. It's irreplaceable, except if we can transplant it. Look after your liver. The liver has two feeding blood vessels. Unusually, it's fed by an artery, the hepatic artery, but unusually for an organ, the inflow of blood into the liver is also from a vein, the portal vein, which, as I'll show you, is derived from gut veins and from the splenic vein, and that's of enormous importance in patients who develop liver disease. This blood flows into the liver, it's acted upon by the liver cells, which have numerous functions, and the outflow of the liver is via the inferior vena cava. So that's the main anatomy of the liver, and it's as well keeping some of this in mind as we talk through some of the issues. We can image the liver very, very easily with modern imaging techniques, particularly CT scans and MRI scans, which many people living with thalassemia would have had to check on iron concentrations. So here you see a number of CT scans showing normal livers situated on the right side, occupying a large part of the upper abdomen, lower chest, underneath the ribs, where it sometimes can be felt if it's enlarged. And we get a very good picture of the liver, its picture, its edge, its parenchyma, its surface, and the vessels that go into it. And depending upon the cut at which we take these views, the vessels which go out of it. So the beauty of the liver is that it's easily accessible to imaging by these methodologies, which greatly helps us to look at the structures, sometimes the function, and certainly abnormalities that concern us within the liver. So the important aspect of liver biopsy and iron content, iron overload, are very well known to the patient groups. And I really don't think I can do better than the guidelines that have been published. Many of you will be very familiar with the management of iron, the consequences of iron overload in thalassemia, the mechanism by which iron is laid down, both from blood transfusion, but also because of ineffective red blood cell development. And many of you will be very familiar of how your iron has been managed on a day-to-day and month-to-month basis. We don't really need to use liver biopsy anymore. In the past, we could measure iron content by sophisticated methodology, but we have much better serum correlations with iron concentrations, including the serum ferritin and ferri scanning, which allows us to tell by a non-invasive, safe technique which doesn't cause discomfort to patients to measure serum iron. At the same time, we are moving away from routine biopsies, although we will still do biopsies for diagnostic purposes in patients with or without thalassemia. The numbers of patients who now need diagnostic biopsies for fibrosis is diminishing rapidly because we have good non-invasive ways of measuring liver stiffness, which is a good surrogate for the amount of scar tissue in the liver, which we call liver fibrosis. And there are other techniques coming along, also known as RFI, which is also a non-invasive, non-X-ray radiographic method using acoustic forces to measure hepatic fibrosis. All these have greatly changed the way in which we've managed patients with chronic hepatitis B and C, and we have some data in thalassemia to show that they are valid. So what are the symptoms of chronic liver disease? Well, patients can feel unwell and tired. That's not very specific, but other patients will report loss of appetite. We would be very concerned that if liver disease is advancing and there's a lot of scar tissue, that we would see loss of weight and muscle wasting. And of course, this can be very difficult, but we do know that in patients with cirrhosis, we get muscle wasting, which is an important issue to address. Patients who get acute liver disease with acute hepatitis can get a lot of nausea and vomiting, and they may get jaundice, of course. But for most of us, it doesn't apply, and we see patients with chronic liver disease who will not actually have jaundice unless the liver disease is very advanced. There may be some tenderness and pain in the liver area, and we see characteristic features on the skin which can sometimes help the physician to diagnose advanced liver disease, including things like spider angiomas or dilated blood cells, somewhat blotchy red palms, and if the liver disease is very advanced, a disturbed sleep pattern. So there are a number of symptoms and signs of moderate liver disease or cirrhosis, too many to go through here. But the important point I'd like to make today is that we really don't want patients to get to cirrhosis. patients with thalassemia or any other patient with chronic liver disease, we'd really like to prevent and treat to prevent progression to cirrhosis. Some of these, like swelling of the legs and ankle and feet, swelling of the abdomen with fluid, which we call ascites, are really very advanced signs of very bad liver disease. Vomiting blood because of swollen esophageal veins. Again, most of us would like to treat and prevent the onset of these complications, all of which are listed here on this slide. But they are late signs of not only cirrhosis, but cirrhosis that's become clinically apparent to the patient and to the physician with decompensation. But it's also true that patients who have cirrhosis may not have ever experienced those specific symptoms. They may not have decompensated with fluid accumulation or have vomited blood or developed an altered mental state, which we call encephalopathy. So you can get patients who have cirrhosis, who've not yet decompensated, who haven't got these complications of cirrhosis, and we must be very aware of diagnosing those individuals. And by and large, we've used hepatic imaging, and we've also used techniques such as the fibroscan to actually diagnose advanced fibrosis. There's certain laboratory tests that help us to diagnose cirrhosis. If the liver's enlarged, that would be very suggestive of an abnormal liver. As I mentioned, there are these skin signs, spider nevi. We can get clubbing or swelling of the ends of the fingers, the muscle cramps, etc. And sometimes you have patients who go into coma with liver disease, a distinctive smell. Again, these are late signs which we would much rather avoid patients reaching by treating to prevent cirrhosis. And of course, there are biochemical investigations. If the AST liver enzyme is higher than the ALT enzyme, that could suggest cirrhosis. If the serum albumin is low, it could suggest that patients are running out of liver tissue and not synthesizing serum albumin as well as they should. And if the prothrombin time is increased, again, that can be a feature of advanced liver disease. So we diagnose cirrhosis and advanced liver disease with blood tests, which include the liver function test. Of course, in the patient with thalassemia, that would include ferritin. And platelet counts can tell us if the spleen has enlarged, as I'll show you, secondary to liver disease, and that may be low. Of course, won't apply in patients who've had splenectomy. We use imaging of the liver frequently. An ultrasound can show us a damaged liver. It is very sensitive for showing us fluid in the abdomen. CT scan, which does involve radiation, MRI scan, which you know, and of course the new non-invasive tests that I've mentioned, like fibroscan. These are very useful. We used to have to rely on liver biopsy. We'd put the liver under the microscope after staining it with special stains. This is a stain with Prussian blue, and you can see this intensely blue photomicrograph of the liver is a result of increased iron overload. But we have much safer non-invasive tests which cause much less discomfort to patients, including scanning. And we use transient elastography every day in our clinic. It only takes a few hours of training to become proficient in transient elastography. There are studies, which I won't go into detail today, which show that it is valid in patients with fibrosis and thalassemia and hepatitis C and thalassemia, for example. So that can give us a good indication of a liver that might have more scar tissue than we would like. And of course, you're all more familiar than I am with Ferry scans, which are an elegant way, although they do require sophisticated computation, of actually estimating an accumulating amount of iron in the liver. And here you can see this dark liver with marked amounts of iron overload in the liver. So how do we treat liver disease? In thalassemia in particular, it's treatment of the underlying disease mainly. Antiviral treatment, which you'll hear about, iron chelation therapy, which you know more about than I do, weight loss and exercise for NAFLD, although there are probably 50 clinical trials in progress examining new drugs that might reduce fat in the liver. And this is something that could become important in patients with thalassemia as hepatitis B and C and iron become less of a problem. And avoid alcohol. It may require lifestyle changes if patients have got advanced liver disease, including ensuring that we don't overload the body with sodium, because that could lead to water accumulation and ascites, and discontinue alcohol. And there are a few specific medications that we sometimes use in cirrhosis, antibiotics in those who've got fluid overload to prevent the ascites from becoming infected with bacteria from the gut, vaccinations to prevent hepatitis B wherever we can, beta blockers that will reduce the pressure in the portal vein, and sometimes medications that will reduce the impaired thinking that is characteristic of encephalopathy. I'm not going to details of the management of liver iron and thalassemia. I really can't surpass the detailed guidelines, but you will know how to diagnose iron overload, what the predictive value of the ferritin is, which is quite good, MRI scanning and ferri scanning, and the good correlation that can exist between the serum ferritin levels specified at a particular cutoff and a starting point for iron chelation. And I think this is very well done in the guidelines, so that most of you will be very familiar with iron and its management. Let me talk about portal hypertension. This is a term you may hear your doctor talk about. In patients with cirrhosis, remember I said the liver has two vessels that supply blood, the hepatic artery, but also the portal vein, which is derived from an amalgamation of the splenic vein, as well as a vein that comes from the gut, known as the inferior mesenteric. This large vein feeds the liver tissue, but if the liver is very badly scarred, the inflow of blood via the portal vein is impeded. What happens then, unfortunately, is that blood chooses another route because this route is under high pressure. And vestigial veins with which we are born, but which we close at birth, open up in the esophagus. These are known as esophageal varices. It's just the medical term for swollen esophageal veins that are broken out because inflow of the portal vein has been impaired. We can measure the portal pressures, and sometimes we can pass a cannula into the liver, and by wedging it into the liver, we can actually tell what the portal pressure is. We can look at the spleen and see it's enlarged as an indication of portal hypertension. And we also see low platelets as the spleen consumes platelets. But we will see fluid accumulating. We'll see veins opening up in the esophagus. We'll see an enlarged spleen, and we'll see raised portal pressure with portal hypertension. So how do we monitor cirrhosis and portal hypertension? Regular imaging is important because we are aware of the risk of primary liver cancer or hepatocellular carcinoma. And the only way to diagnose this early is to put patients under regular surveillance with ultrasound and alpha-fetoprotein. We do endoscopy to look down the esophagus to see if these veins are developing. If they're there and if they look dangerous, they can be banded. We can put patients onto beta blockers, which reduces the pressure in the portal vein circulation. And we can also measure this so it becomes quite objective with portal pressure monitoring. The treatment of portal hypertension is beta blockers. I'll show you what we can do to sometimes shunt away blood from that high pressure portal vein. Sometimes we need to manage the bleeding varices by either preventing them from rupturing and bleeding, or by actually dealing with the bleeding varices. We have a number of techniques for doing that. And if patients are decompensating and they're suitable candidates, we can use liver transplantation. So you'll remember the CT scan that I showed you of normal livers. This is an abnormal liver. It's small. It has a very irregular edge. You can see the portal vein is swollen. The spleen is enlarged. And also there has been an accumulation of fluid, which is easily visible on the scan, showing ascites. The treatment of ascites is to reduce fluid. We can give patients a diuretic, which is a tablet used, for example, in patients with high blood pressure that makes us lose that excess fluid through the kidney. And sometimes we need to actually put in a needle into the abdomen and remove liters of fluid by what's called a paracentesis. And that done under safe conditions can be very helpful. Again, all these are features of very advanced liver disease, a situation we would like to avoid. That fluid is susceptible to being infected by bacteria from the bowels or the gut, and we have to treat spontaneous bacteriopneumonitis. And sometimes, if there's a lot of ascites, a lot of portal hypertension, we could actually shunt that, and we have to watch the kidneys very carefully because they seem to be very sensitive in patients who've got chronic liver disease and can easily become impaired. So this is a picture of a TIPS. There may be occasional patients who have actually had a TIPS amongst the patients, but essentially what we can do is by guiding a catheter and a stent into the liver by going down the veins, we can actually shunt blood from this portal vein under pressure directly into the vena cava. So we bypass that very high pressure circulation and simply shunt the blood away, easing its passage through the large vein that comes back to the heart. That's called a TIPS. We have to be careful how we use it. It's not recommended for patients who have very advanced liver disease, and it can cause liver coma or encephalopathy because we're shunting away blood from the liver, and the liver functions to actually remove a number of compounds that can cause this. What are the risk factors for primary liver cancer? Cirrhosis and viral hepatitis are the major risk factors. We're now seeing obesity, non-alcoholic fatty liver disease, and diabetes as being important. Excuse me, clearly the age increases the risk, and males seem to be more at risk, than are females. And in some countries, there may be environmental factors. Diagnosis is made by regular surveillance. We like to keep patients who've got cirrhosis with regular image, doing an ultrasound, and we do an alpha-fetoprotein as well. And that enables us to detect a small tumor. If we need to characterize it further, we'll do other scans as well. Some patients with liver cancer can experience no symptoms. When it's small, it will not be symptomatic, but that's important for us because we'd like to keep patients under regular surveillance, and using the imaging technique and alpha-fetoprotein that I mentioned, we can detect small cancers as small as the size of my thumbnail, 1 centimeter in size. And at that stage, they're very easy to treat with good results. So if symptoms and signs of a liver cancer have occurred, this means the cancer is much too large, usually not amenable to surgical resection, but unexplained weight loss, weakness, a pain in the abdominal area will be seen with large tumors. We'd certainly like to avoid that. And through regular surveillance, we can detect small tumors in the liver, again shown by imaging here, which are highly amenable to a number of potentially curative and certainly good palliative treatment. How do we treat liver cancer? It entirely depends upon the stage and the size of the tumor, and that's why we like to detect it early. We can remove that portion of the liver. Liver transplantation is considered curative, but we can only do that if specific criteria are met, namely the tumor small. There are ways that we can target the artery of the liver or inject ethanol directly into the liver, which will shrink it down, and these can be very effective and are generally reasonably well tolerated by patients. And we can also use a catheter to feed in a chemotherapeutic agent, and we can use cellulose particles to actually block off the artery, which will damage the tumor. And also systemic therapies. There now a fairly substantial number of new drugs which are improving the outlook for liver cancer. Comes back to the first point I'd like to make, that I think the outlook for patients with liver disease and thalassemia is hopeful. It's hopeful because we've got improved iron control. It's very hopeful because we are testing quite widely in those at risk for hepatitis viruses. As you'll hear, we've got improved treatments for hepatitis B and C. We can improve the management of cirrhosis if we haven't been able to prevent cirrhosis. We'd like effective and appropriate surveillance for liver cancer so we can deal with tumors if they occur when they're small. Not quite sure what the ultimate risk for primary liver cancer in patients with thalassemia will be as we improve the outlook from B and C, but going forward, surveillance is, I think, important for all patients. And once again, just to close, it's better to treat early and to prevent cirrhosis. Thank you very much.
So thank you very much, Professor Dusheiko, for this very, very comprehensive and I hope well understood to everyone, but we're open to questions, I'm sure. So may I introduce my co-chair? This is Dr. Michael Angastiniotis, medical advisor at TIF. And I assume that it's much better if we finalize with Professor Koskinas. Do you prefer? You've got the time, Professor Dusheiko, for the questions after the two of you. Thank you so much. So, Professor Koskinas, thank you again so much for your contribution, and the floor is yours.
Dr. Eleftheriou and the organizing committee, thank you very much for this kind invitation. I'm always happy to try to present some data and educate our participants, our patients. Let me, 1 second, please share my screen. Do you see my slides?
Not yet.
It's starting.
It's starting to probably download.
Right. Is that now clear on your screens?
Not yet.
Not yet.
Right.
Share screen, πατήθηκε το share screen από τον καθηγητή.
It's a started.
Started sharing screen. Okay.
Can you try again, please?
We can see you, but not your slides, Professor Koskinas. Can you try again? Thank you.
Okay.
Right. Lovely. Thank you.
Do you see that now?
Absolutely. Yes. Thank you.
Yeah.
Right. Do you see the change as well?
Yes, yes.
Okay. Now, dear friends, dear network friends, I will try to present some data on viral hepatitis in thalassemia patients with great concern on prevention, eradication, and treatment. This is my conflict of interest. So you are all of you aware of the geographical distribution of thalassemia and sickle cell anemia. I'm not going to discuss these things. And concerning hepatitis viruses, we do have those viruses that they cause acute infection, like hepatitis A, hepatitis E, hepatitis B, Delta, and HCV. And some of these viruses, particularly hepatitis B, with or without the parasitic virus, the hepatitis Delta virus, and the hepatitis C virus, and in some cases, in immunocompromised patients, it means those patients who are on immunosuppression, they may lead as well as the other ones to chronicity in some cases. So chronic hepatitis virus, B and C, very slightly has been presented by Professor Dusheiko. They may lead to cirrhosis if they go to chronicity, and then they may go as well to decompensated cirrhosis or development of hepatocellular carcinoma. That's very important to understand and treat those patients, individuals with chronic hepatitis B or chronic hepatitis C. And very nicely as well, Professor Dusheiko has given you the details of how you really investigate and confirm the presence of cirrhosis. You have the clinical, which is at the late stages. You have the gold standard, which is the biopsy. We don't do that. It's an invasive technique. You have the ultrasound and the triplex of the portal vein. You have the fibroscan, the elastography, and you have some mathematical scores as well that you may really rule out patients, or you can confirm the presence of cirrhosis. Now, what I'm going to discuss later on, I want you to know as well that apart from the natural history of the underlying liver disease, if being untreated, from cirrhosis compensated to decompensated cirrhosis with ascites, with variceal bleeding, you may have some acute insult on an underlying liver disease, which is another probably virus or an infection or surgery that may cause acute or chronic liver damage and failure. So having that in mind, you will understand talking about some hepatitis virus later on. And this acute or chronic in certain areas, the cause could be hepatitis A infection or hepatitis C infection or hepatitis B infection, particularly in East countries, not in the West, which is the major cause of that is infection. Now let's go and move to hepatitis viruses, and let's start with hepatitis A. This is the geographical distribution of hepatitis A virus infection. You see areas with the red color with the high prevalence of hepatitis A. And how does it spread? It goes fecal oral. You swallow the virus by contaminated food, by germs from poop, touching contaminated objects, or maybe probably sharing drug items. What's the symptoms of hepatitis A? It's the same as for every acute hepatitis. You may have fatigue, you may have fever, you may have nausea, or you may have nothing if you are of very young age. And of course, you may have jaundice. That depends on the severity of your hepatitis A infection. And it is more serious, and this has to be presented very elegantly to you, because it's very serious. It could be very serious on patients having diabetes or other liver disease or hepatitis C. And how we can prevent hepatitis C, we have to be very carefully about the way that we may get the hepatitis A, but at the same time, we have a very good vaccine to prevent hepatitis A infection. So the hepatitis A vaccine is very, very, has a great efficacy. It's given in 2 doses, the first dose, and after 6 months, the second one, and you get a very nice results in terms of antibodies that they may protect you for life. So recommend those patients who have underlying chronic liver disease, and our thalassaemic patients, they may have underlying liver disease, or sickle cell patients with sickle cell hepatopathy. So it is very, very crucial to test and do hepatitis E vaccination. Now let's move to another virus that causes usually the self-limited acute hepatitis, and this is hepatitis E infection. You see here the epidemiology worldwide and the deaths related to this infection. Now we do have a lot of genotypes for hepatitis C. We have the genotype 1 and 2. This virus is transmitted from one human to another human by oral fecal route of transmission, like hepatitis A infection, and you have the hepatitis E 3 genotype or 4 genotype, that it is a zoonotic. It means that it's transmitting from animals to humans, and usually from uncooked pork. We will discuss that a little bit later. So you have in the endemic areas, mainly from contaminated water, the fecal-oral route of transmission, but you have in non-endemic areas, particularly in Europe, you get this virus from uncooked food. So what is the course, the clinical course of hepatitis C? You see here in healthy people, it is self-limited acute hepatitis, mostly asymptomatic. But what happens in a certain group of patients or other group of individuals, let's see what happens to the pregnancy. It can be very severe with it could be very dangerous in pregnant women, and it could be as well, it can cause acute, as I discussed before, acute and chronic liver disease in those patients that they may have underlying liver disease. Now, what happens with HIV infection screening in blood donors in patients with thalassemia? Should we screen the blood donors for hepatitis C infection? That's really a question. You see here the presence of the hepatitis E virus RNA in healthy donors, and you see the prevalence of that in India, where it is endemic for the hepatitis E infection. But you see in other countries, in Europe countries, the prevalence of really presence of hepatitis E virus in donors is very, very low. And you see here the prevalence of the IgG antibodies to hepatitis E virus in blood donors. And you see this is a geographical variation, and not only geographical variation, but from country to country, but in the same country as well. So in UK, the acute hepatitis C relates to transfusion in less than 1% of patients. And most of the others, it is through the uncooked pork. And you see here that some really countries, they do have screening programs for hepatitis E infection. Other countries not. That really depends on the cost effectiveness and the prevalence of the hepatitis E in the general population and the endemicity of the virus. So what should our patients, they should probably be very aware to avoid consumption of uncooked pork, wild boar or deer, and have a very good hand washing if they visit the toilets. And of course, it is an issue and the question, and that really depends on the country, if we have to screen for special group of patients for thalassaemic, I mean the blood donors for hepatitis C infection. Now let's move to those viruses that they may cause chronic infection, and hepatitis B virus, DNA virus. You see here the prevalence in the carriers worldwide, and the impact of immigration as patients, individuals, they are moving from high endemic to low endemic areas. So it's very important these days with the immigration. Now, the hepatitis B is transmitted horizontally from one to another by drug users in sexual contact, or it could be as well transmitted from mother to infant as well. The transmission through transfusion is extremely rare. Now, as the acute hepatitis B infection may cause chronic infection in the majority of infants if they get infected with a virus in a very, very young age, or in less than 5%, usually less than 1% in adults. And most of them, they may have no liver disease. Those that they have chronic hepatitis, they may develop later on if no treatment is offered to our patients to cirrhosis and then decompensation or hepatocellular carcinoma. How we decide to treat patients with hepatitis B, this is really based on biochemistry, aminotransferases, viral replication, HBV DNA, liver damage, states of fibrosis, other liver diseases, and of course, if there is old age and family history of hepatocellular carcinoma. We do have short duration treatment and we have long duration treatment that we use recent days. You are aware of these drugs, of course. And what we really do with these medications, we, as we say, we have a biochemical remission and also a virological remission. So our aminotransferases are normal. There is no inflammation in the liver and there is no replication of the virus. Sometimes you may lose the hepatitis S surface antigens, and then this is a very good outcome, which we call it a functional cure, but it is not common. The most common response is this one, which we get in most of our patients, in more than 95% of our patients. But for this kind of virus, we do have a vaccination. So we have the vaccine, 3 doses, now in 1 month and in 6 months. The vaccine is safe. There are no side effects. The efficacy is very high, and you don't need booster injection usually to have high antibodies against virus to protect you. And the protection is for life. So who should probably vaccinate? Of course, general population, children, and of course, special groups, and of course, patients with underlying liver disease. Let's move now to the other virus, which is the hepatitis C virus, which for this virus, we don't have a vaccine. This is an RNA virus. It was isolated in 1989 for the first time. The route of transmission, it's again, like hepatitis B, horizontally through sexual intercourse, from mother to child transmission of very high rate, and of course, in patients or in individuals that they use common needles for drug use. In those with unsafe injections and medical procedures, it is a major problem in underdeveloped countries where the blood is not screened for that. There are countries you pay to get blood. And that accounts from 2 million new cases per year. You see here the prevalence of HIV infection among patients that use common needle, the drug users, individuals. In the past, before 1990, of course, there was no screening for the blood donors. So all the patients that have been transfused before 1999, they had maybe they have been infected with hepatitis C virus. Nowadays, with the screening, with the molecular screening of for hepatitis B, for hepatitis C, and for HIV, the transfusion through blood is extremely rare. You see here the epidemiology of hepatitis C virus in different countries, and here you see the proportion of genotypes of the hepatitis C virus in each country. Now, if you get hepatitis C virus, you may you may clear the virus in 20–30%, or the virus can go to chronicity in most of the cases, in 70–80% of our cases, of patients that have been infected. And how you recognize, how you really diagnose your hepatitis C infection, you do the test, the antibodies test. If it is negative, it's absence of HCV infection. If your test is positive, you do the molecular test, You test for HCV RNA for the virus itself with a very, very low detection method. And if it is positive, your HCV RNA test, then you confirm that you have HCV infection. If this is negative and your antibodies is positive, it means that you have spontaneous clearance after acute infection. Now, what happens with hepatitis C virus in patients with thalassemia is the patients now with the liver with thalassemia, they live longer because of the many chelated agents and the improvement of therapy in cardiac problems. And you see here the decline of the heart disease in those individuals. But at the same time as they live longer, you may see the consequences of the liver diseases, either hepatitis C or iron deposition. So in thalassemia, the iron deposition, the HCV infection is the main causes of probably chronic liver disease that may lead to fibrosis or cirrhosis. And you are aware all of this figure that patients with high iron and hepatitis C, they are really had the worst survival, the worst prognosis. So what we have today, we are really have the gold age in the treatment of hepatitis C virus. We have treatment that we can give to our patients really a very high virological response to clear the virus in more than 95–97% of our patients. And we have drugs that they really attack in various stages of the HCV replication. And we do have really first-line pangenotypic drugs, you can see here. And in those patients that they don't get response, you don't clear the virus with these first-line pangenotypic regimens, you have a pangenotypic second line that they confirm very high efficacy in 97% of our patients with thalassemia. These medications are quite safe. They have no side effects apart from fatigue, which is very, very mild. Practically, they don't have any side effect. And there are some drug-drug interactions. You may see that in a website that you can check the medications that take your patient and your medication that you want to give you to your patient. So there are really very rare contraindications. Amiodarone antiarrhythmic medication is one of them that you have to avoid or to stop. And these drugs for the hepatitis C virus are quite safe with the iron chelating drugs. So they can be given together. So the WHO has really an ambitious global targets to control viral hepatitis in the general population, but we have also the macro elimination. And this is a program we have developed many years now, a couple of years before now in Greece with 150 patients with thalassemia that have been treated with DAEs, with antiviral drugs, and most of them, and all of them, they have been treated. Some of them, they have failure to the first generation of the drugs, probably because those medications, they were very early. We didn't know much about that, and it was not recommended for today. We have better drugs today that they are given without the necessity to give ribavirin, which may cause hemolysis. And at the end, I will discuss a little bit about the hepatocarcinogenesis. This is really something that we need to avoid. The chronic infection, the hepatitis C, the hepatitis B, the iron in the liver, and the chronic hepatitis, they may really give presence to dysplastic cells that eventually they may go and develop hepatocellular carcinoma. And in our series, you see here that the patients with a hepatocellular carcinoma are younger than those patients that they're non-thalassemic patients. Those, all of them, they don't have all of them hepatitis C infection. The iron deposition, it was mild in the majority of them, but we don't know what was in the past. 80% of them, there was cirrhosis. It means that some of them, they are not cirrhosis. And unfortunately, the diagnosis was at the very late stage with multinodular hepatocellular carcinoma or with high tumors. And this is very important because the survival of the hepatocellular carcinoma in our thalassemic patients, it really depends on the Barcelona Clinic Liver Carcinoma score that you will see, the score that you really assess the stage of the hepatocellular carcinoma and the underlying liver disease. And you see those that they had the Barcelona stage A will live longer, and those that they really be diagnosed with late stage, they have the poorest prognosis. So, but it is very important, as you understand, looking at this classification and treatment figure, at the very early stage, you may have very many opportunities, many therapeutic regimens. You may resect the hepatocellular carcinoma, you may ablate your lesion, or you may offer transplantation to your patients. You see the survival, the 5-year survivors, if you really, our patients are in the very early stage of hepatocellular carcinoma, and you can really see how bad is the survival in those patients, they coming with the advanced stage of the hepatocellular carcinoma. So what are the points that I will want to discuss to take home messages to our participants and our patients for viral hepatitis and thalassemia? First of all, as Professor Dusheiko has really very nicely presented, the systemic iron and continuous systemic iron chelation therapy that you will check with the MRI leak, the iron in the liver, and the ferritin levels. You have to treat all your patients with hepatitis C now with very safe, very efficacious drug that you don't need any more ribavirin. You have to treat those patients with chronic hepatitis B infection. If there is no evidence of past infection, you have to vaccinate your patients with hepatitis B, and you have to vaccinate your patients with hepatitis A. And for hepatocellular carcinoma surveillance, you have to do an ultrasound, which I recommend that should be given every 6 months in your patients, independent of the presence of cirrhosis, by a very experienced radiologist. In case of a suspected lesion detected by regular ultrasound, you have to do an MRI, which is more accurate than CTC with contrast and measurement, of course, of alpha fetoprotein. Inform the patients about the transmission. The patient should be informed about the transmission routes of hepatitis viruses and the precautions they need to take for prevention, particularly for hepatitis A and for hepatitis E virus infection. And of course, the molecular screening for hepatitis virus is in blood donors. It's a government policy, and it is given in most of countries. So I will probably end my talk with this that has been told by the philosopher, the Greek philosopher Aristotle, many, many years before Christ. Don't treat my disease like being an idiot, but firstly, explain to me the cause of the disease, and then I will be persuaded and I will follow your instructions. This is a free translation to understand about this phrase of Aristotle. And so thank you very much for listening to me.
Well, thank you so much for this excellent, comprehensive presentation. And you have ended up with a very good statement from our Greek philosopher Aristotle, which very much aligns to our efforts for adherence of our patients to adherence to the difficult, challenging sometimes treatment of such a chronic disease such as thalassemia. Thank you so much. Of course, I have to give the floor to some questions before I ask one of mine. Let us see. How frequently should we monitor the liver function testing? Professor Dusheiko, let's go by in turn.
I think you'd like to get a baseline liver function test in all the patients referred. Look very carefully whether they have ever been infected with hepatitis B or C and the state of their iron in the liver and other organs. I think for some individuals who you establish have good liver function, it would be reasonable, assuming the hep B, if it needs treatment, is being treated, assuming the hep C has been treated and cured, you'd like to see near normal liver function test. And in those individuals, I would think it really is a matter of monitoring iron and liver function perhaps once a year. But it would depend upon the baseline levels of iron and their baseline stage of liver disease reached before the hep B was treated or before the hepatitis C was cured. So monitoring, I think, has to be fairly flexible. Some patients we could monitor more frequently, but it would depend upon their status. And I think that they're very easy tests to do. So anything between 3 monthly and annually, depending upon an individual's status and assessment and their workup, would, I think, dictate how frequently we should measure them.
Thank you. And this is a question from me to both of you. Is there any level of the liver function test that you would say that they differ in this group of patients? For example, the upper limit of the liver function test for thalassemia would be the ones that we would follow as in the sort of population, the normal range, because I've heard that some levels of the liver function tests that are considered normal in the rest of the population, perhaps they should warrant a further investigation for these patients. Is that so? Do you believe, or is there no documentation or evidence for that?
Shall I start by answering?
Yes, please.
You know, I think that we've come to lower the levels of aminotransferases, which we consider normal. So the ALT, AST, SGOT, SGPT, we used to take a laboratory abnormal of around 40. Yes. Nowadays, we recognize that's probably too high. It should be around 35 for men and around 25 for women. My feeling would be that we shouldn't accept a different normal range for patients with thalassemia. If they're abnormal, and we set that bar fairly low now, there's a reason for it. It's either iron, or it's hepatitis, or it's fat, or it's something else. But I don't think we should set them at a different threshold for patients with thalassemia personally.
Thank you. Professor Koskinas, do you share?
Yes, I do that. I don't think that you have really to differentiate those patients in terms of levels of normal aminotransferases. What I would like only to say is that in patients with iron deposition, you may get fibrosis, you may have progression of your underlying liver disease in terms of fibrosis in the presence of normal AST, ALT. So sometimes really the liver function test does not really reflect the progression, particularly in those patients that the cause of this progression is iron deposition.
Okay, that's for the progression and the iron deposition, which doesn't reflect really. Okay, thank you so much. So another question. So everybody's thanking you for your lectures. At what intervals of time should the hepatitis B vaccination should be activated? The vaccine usually is given at childhood and followed by only one activation dose. Is this enough or should be activated every now and then? Of course, by activation, you understand what they mean.
They're talking about booster.
They boost the dose. Professor Koskinas?
Yes, okay. Usually, if you confirm that you have after vaccination antibodies, high levels of antibodies, you don't need a boosted infection because you have memory cells that if you get hepatitis B infection, they can produce really high levels of antibodies against the hepatitis. So usually you don't need a boosted infection if you have a confirmation that sometimes in the past you have antibodies, you have really a good response to the hepatitis B virus infection.
So that's very important to measure the level or the presence of the antibodies after vaccination, and that means that the memory cells would work for the rest of the time. How often should LIC, the liver iron content by ferriscan be done in non-transfusion thalassemia? Maybe Professor Dusheiko? How often should the LIC by ferriscan be done in non-transfusion thalassemia?
I think this is really a question for the hematologists who know better.
Yes.
It's an interesting and important question.
Yes.
I would imagine that you have a baseline ferriscan in a non-transfusion thalassemic, and if that looks good, my understanding from your guidelines is that these are yearly ferriscans that would be mandated for most individuals. Whether an individual who has a low liver iron concentration can extend that out to an interval longer, I'm not sure I have the answer, but I'd be interested in your answer. I think it would depend upon the baseline in a non-transfusion thalassemic.
Yes, it does depend on the baseline, and certainly the level of the LIC in non-transfusion dependent thalassemia is quite differently observed by the hematologist as far as their clinical significance is concerned than, and I would refer to our guidelines for non-transfusion dependent thalassemia. Michael, do you want to add something?
No. Non-transfusion dependent thalassemia, of course, is iron loaded usually by absorption from the gut, and therefore it's a slower process. So yes, I would still do it every 2 years, unless I see a high level, in which case a yearly monitoring should be done.
Thank you. Thank you so much for the excellent talk. It says, do you have any experience in both liver and bone marrow transplant at the same time, liver and bone marrow transplant in decompensated cirrhosis or hepatocellular carcinoma in thalassemia patients with any HPV or HCV infection?
I have no personal experience, and I think the numbers would be very low.
Mm-hmm.
The Federation may have better numbers. We could search the literature to answer that question and get back, but I have no personal experience of bone marrow and liver transplantation. I think it would be a major undertaking. They're two very different operations with profoundly different effects on immunosuppression. I would think that these would be staggered, certainly not simultaneous, would be very difficult, but I'm not sure what the world literature on both bone marrow and liver transplantation is. It's an answer I'll have to look up.
Thank you. Professor Koskinas, do you have any experience at all?
Yes, the cases with bone marrow transplantation and liver transplant are very, very really low. But what I would like to say on your question is the transplantation therapy that has to be offered to these patients, because most of the centers in the past, they were very reluctant to transplant patients with thalassemia or patients with sickle cell disease because of the outcome of the transplantation. But I think now it's necessary to evaluate these patients, not to exclude them a priori about from transplantation. If they do have normal heart, no iron deposition, or you don't have pulmonary hypertension, if they don't have really critical organs damage, and they have only the liver disease, then they should be offered this opportunity for liver transplantation.
Thank
And
you.
there are some centers, and I know that in UK and in France as well, they do have a lot of experience, and they start to have experience with patients with thalassemia and end-stage liver disease. So you have to keep our patients as well, very good as well, from the pulmonary hypertension and then the heart failure and the consequences of the iron on those organs.
Yes, thank you very much. And as far as the participant's question is concerned, I'm sure we will look into the literature. TIF also has no experience on this, but as Professor Dusheiko and yourself would be very grateful if we can answer to the participant's question, because I'm sure that was very targeted. So the other question, in which, now if the ultrasound of the liver is okay, should we still measure the T2 through MRI?
But the ultrasound does not measure.
These are two different things. Dear participant, of course the doctors can answer. The ultrasound does not measure iron load. Professor Dusheiko?
I would agree with your answer. What you really want an idea of liver iron concentration, and for that you'd want specific measurements of iron concentration. The ultrasound is looking at structures of the liver. It can look very broadly at the hepatic parenchyma. It can find small masses in the liver, but it's not a good test for liver iron. And you need to follow a strategy of assessing liver iron as per the guidelines.
It's very important for the participant who is answered this to know that both of them are essential in the appropriate monitoring of our patients, both the ultrasound and the T2 star. In which countries in ASEAN area are doing anti-HIV tests in blood donors? In which countries in the ASEAN area are performing anti-HIV tests in blood donors? Well, from my point of view, I would answer that this is not a routine testing, obviously, the anti-HIV, but maybe Professor Koskinas knows a little bit about the epidemiology of blood donor testing in the ASEAN countries.
I'm not aware of that in the Asian countries, if they do really do the screening test on the blood donors. I know in Europe what they are doing in some countries. Some of them, they are thinking of doing that. Yeah. Or in patients with a high risk of infection, like the thalassemia, they may screen those. I have no idea about the policy of screening in those Asian countries.
Dr. Koskinas, what about data on hepatitis E superinfection or infection in thalassemia patients? Are there many reports?
Now, I did have one finger in my talk. I didn't really discuss that one. There was a report from a thalassemia center in Salonika, in northern Greece, for our participants, and they didn't find any really thalassemic patients with very few of them with antibodies, and about 3 to 5%, if I remember well, antibodies against hepatitis C virus in blood donors. Mm-hmm. What I can assure you that there is no really, we haven't been across any case of acute hepatitis, apart from only one who had been transfused in all those years. Only one who has been transfused for hepatitis C and developed acute hepatitis C, but there was really a self-limited acute hepatitis with no problems to the patient. So it's very, really rare. You don't see cases in Greece, at least.
Okay, thank you. So for the participant, again, we will have a look if there is a blood donor screening for anti-HIV. My impression is that it is not, because we are trying very hard to put the rest into testing for the blood donor. So I think anti-HIV is highly improbable that it's being tested. It's being tested probably at particular populations and in particular cases, but not as their routine blood donors. But we will look into it and answer to the participant. How often fibroscan should be done in thalassemia major adult patients? How often fibroscan should be done?
Again, I think if you have a good low fibroscan reading, then you don't need to do it very often, because you're assuming the rate of progression of fibrosis in an individual would be relatively slow. So a low fibroscan reading is very helpful. I think if you have a reading that is going up and you have someone with active hepatitis B and C, for example, a fibroscan reading this year might be something like 5 or 6, we would probably want to do that once a year. It's a very easy technique to do if you have access to a fibroscan. And if you have active hepatitis B and C, then it would be important to monitor. However, most patients with active hepatitis B and C, as Professor Koskinas pointed out, should be treated, and that would again reduce the fibroscan or hold it. So that could be done, I think, every 2 to 3 years in patients in whom the condition has been stabilized. And the same would apply, I think, to iron. So depends upon the baseline again, and something between once a year and once every 3 years, depending upon the circumstances.
The safe quantity of antibodies for HPV? 10. Dr. Koskinas, what is the safe level of antibodies? Probably they mean after HPV vaccination.
It should be positive after 10 international units, but in some patients we may need above 100.
Yes.
So we say that the vaccine, there was a response to vaccine if you have antibodies above 10 international units, but you may need to above 100 in those patients that they are probably immunosuppressed somehow.
Or more vulnerable. Thank you so much. So this is a good answer and a good question. 10 international units is what the test kits give as effective antibody response. But for these patients, for our patients, it may be most probably true and more accurate to expect more than 100 international units. Thalassemics receive a cocktail of medication throughout their lives, and that's true. Polyorganic disease, a cocktail of medications. Could the toxicity of this contribute to the fibrosis and cirrhosis? That's a good question, actually, and I would like both of you to give your perspective. Professor Dusheiko?
Well, it's a good question. I think, there are several medications that can be associated with DILI, which is drug-induced liver disease, and this would apply equally in patients with thalassemia, whether they are medicines widely prescribed in the general population or specific for patients with thalassemia. I would think it's a fair point, and that comes back to the point that was raised very early on about monitoring liver function tests in patients with thalassemia. If patients are stable and their transaminases remain stable, perhaps the introduction of a new medicine should mean that that individual should have liver function tests measured a bit more frequently. Instead of doing them at 9 months, you would bring it forward to 3 or 6 months just to monitor the introduction of a new medicine. And over the life of the patient, we would want, I think, to just keep a careful eye on any association between a medication and abnormal liver function test. Drug-induced liver disease is common. It's really quite common. It can be a very common manifestation of drugs that are widely used, or sometimes can be what we call an idiosyncratic drug reaction, which is very rare, but you have to monitor for both of those. And again, monitoring bilirubin, alk phos, serum ALT and AST is relatively easy. Introduction of new drugs, I would monitor the liver carefully.
Okay.
What can I say something on that?
Yes, absolutely.
The thalassemia patient does seem to be more vulnerable to drug-induced liver disease. But sometimes this liver injury in those patients that have underlying liver disease, it may have a not very good prognosis, and they may give really problems to our patients. So we have to follow the patients that they get a new medication, doing more routinely the liver function test, and be aware of the consequences of the drug-induced liver injury in those particular patients. But they are not more sensitive or vulnerable to develop drug-induced liver disease.
Okay, thank you very much. In non-transfused intermedia, is fibroscan essential or only LIC? Well, okay, the answer is that it is essential, both LIC and fibroscan. But yes, Professor Dusheiko?
I think I'd like to get a baseline fibroscan in patients with thalassemia, both transfusion dependent and non-transfusion dependent. It gives us a good reading. And if you get a low reading, that's very reassuring for the patient to say your reading is low.
Yes.
We don't see evidence of scarring. It's a very easy and painless test to do. If you have access to a fibroscan machine, use it.
Yes, thank you. Do we need to check surface antigen only or hepatitis B combo to detect occult B infection, occult B infection? Professor Koskinas, occult B infection is more common in Asian countries than in our countries.
I don't understand. I don't really. What is exactly the question? If we have to test for something else apart from hepatitis B surface antigen to detect occult infection, what is the question exactly?
Yes, the participant is asking whether surface antigen testing is enough to diagnose an occult hepatitis B infection.
No, it's not, because occult infection, it means in the absence of the hepatitis B surface antigens, and sometimes in the absence of anticore antibodies, you may have detectable HBV DNA.
Exactly.
But you don't have to do that in your clinical practice in an individual with thalassemia routinely. If you give a patient immunosuppression, or if you give drugs that they may really delete your immune cells, then you may need to know if your patient before had evidence of occult infection. You may need to do the HBV DNA test or to detect the surface antigen, but not with the routine method, because they're very high sensitive. But the absence of surface antigen does not exclude the occult infection. You need the HBV DNA, and you don't have to do that in your clinical practice for everyday patients.
Exactly. I just wanted to mention that the occult, it's exactly the absence of surface antigen that is related to the occult infection. So yes, do you need to add anything, Professor Dusheiko? No. How frequently should thalassemia major patients screen themselves for HCV and HBV? Okay. This is a common question, but I think it's well described in the guidelines. Just a very short statement from you, Professor Koskinas. How frequently should the patients screen themselves for HCV and HBV?
How frequently?
How frequently?
Well, that really depends on the country, but I think the presence, those patients with hepatitis, without hepatitis C that are transfused are really, it's unlikely to get hepatitis C infection. But once a year, I think it's a good time to do this test. If you think that your patients in a high risk population to get hepatitis C infection, not through transfusion, but usually from the style of life or any other evidence that can be exposed to the infection with hepatitis C.
Of course, but the question is, how often should we screen for
Once a year, once a year.
Oh, okay.
Yeah.
Thank you so much. What's the other one? How many thalassemia patients put convenience and cost over blood safety while selecting a blood bank and hospital? Please urge all patients to go for safest possible blood available in their city, be it not ELISA. Blood safety is most important to prevent HCV. This is a statement probably from a patient expert or a doctor that is following us. And of course, this is the position of World Health Organization, of every policymaker, of every hepatologist, and of course of Thalassemia International Federation. We should go for the safest blood. However, in some countries, one needs to investigate and one needs to know, and there needs to be transparency in the blood transfusion centers of what we mean by safety and how a transfusion service safeguards the safety. So this probably doesn't apply for a number of our countries, because we know that we have national competent authorities in the Western world. And so the national competent authority needs to follow very strict regulations on safeguarding the safety of blood. In some other countries, however, there is not such strict regulation and national competent authorities. And in that case, I would very much agree with the participant that investigation and a real reassurance should be made in order to go to a safe blood transfusion center. Okay. Is hepatitis A vaccine recommended for all thalassemia major patients, Dr. Koskinas?
I would suggest so.
Yes, the suggestion is yes, because of the probability of clinical severance in a co-infection with another virus.
The co-infection can really worsen the underlying liver disease, or it can be very severe sometimes. And everybody is exposed to that one, particularly those that they travel abroad in countries where this one is very high endemic.
Good. That's
so I think it's very safe, and I think we have to recommend in all our patients with thalassemia.
Thank you. And how much high bilirubin is normal in thalassemia major? So what's the normal range of bilirubin in thalassemia major?
I think it's a good question, and I saw that answer coming down. I looked up a paper which was published in the European Journal of Hematology in 2011, and the questioner is quite right to answer the question. So I should have said so, but the bilirubin is slightly higher in patients with thalassemia because of red cell breakdown, shortened red blood cell life. This particular paper looked at differences in bilirubin concentration between those who had alpha and beta thalassemia heterozygotes, and they suggested it was slightly higher in beta thalassemia heterozygotes. The other thing that could influence this is Gilbert syndrome, which is pretty common. Gilbert syndrome is a condition, it's a genetic defect in the conjugation of bilirubin, so it will elevate the indirect bilirubin. So I think the answer is that we could expect thalassemic patients of varying genetic backgrounds to have a slightly high indirect bilirubin. It might be higher in those who've got the Gilbert's gene. However, the rule of thumb for liver doctors, if we see a very high indirect bilirubin, somewhere between 50 and 60, that's something else. That's a gallstone or obstructive jaundice, etc. So I would accept a small increase in bilirubin in thalassemia generally. Might be higher in those who've also got a Gilbert's gene, which is common. But anything that's starting to get higher, we should investigate and see what might be obstructing like a gallstone, something else also fairly common. So thanks for the question.
Thank you, Cheryl, for the answer. Well, somebody is asking about the safety of vaccination in patients on hydroxyurea. Professor Koskinas?
Sorry, what was the question? What is the safety of vaccination in patients
who are on hydroxyurea?
What do you mean by safety in those patients? I'm not aware of any.
They probably mean that is vaccination contraindicated, which I don't think it is, but your answer is vaccination contraindicated on patients on hydroxyurea?
From what I'm aware, no, it's not contraindicated.
Do you have a different opinion, Professor Dusheiko?
Could you repeat the question?
Is there a contraindication to vaccinate patients on hydroxyurea? No. So, dear participant, no, it is safe to vaccinate. We only have another 2 questions, very short. When would the FibroScan and T2 procedures monitoring begin in newly transfused patients, children, and how often? So it's the age of initiation of FibroScan and T2 in newly transfused patients.
I think the guidelines would help us here in terms of liver iron monitoring. The FibroScan, I think one wouldn't expect rapidly progressive fibrosis in young children.
Yeah.
So that could wait, I think, until adolescence.
What we agree as well, that FibroScan could wait, but T2 procedures should start after a few transfusions. Quite early.
There's actually a paper by the Bugas that suggests that iron overload in the liver could start much earlier. And so late childhood, 8 or 10 would be a good, reasonable time to start measuring iron.
And certainly the FibroScan has been used in children, it's been used in pediatric liver disease, so it would be perfectly safe to do.
It would be safe, but probably unnecessary.
Yes.
Correct.
So the last one is, what is the best chelator for liver iron overload without cardiac iron overload? So the best chelator for liver iron load if the cardiac is free of iron. Of course, this is a question for a hematologist, but there we are. We have 2 eminent professors. What do you think, Professor Koskinas and Professor Dusheiko? Very difficult question.
It is a very difficult question. I would prefer not to give this really clear answer for that, although we know that one, because I think it's the hematology point of view that should probably answer this question. There is one that is probably better than the other one, apart from the despheroxamine, that has really a good chelation in the liver. It's obvious which is one, but I don't think I should make any strong recommendation in the absence of hematologists.
Yes, I think you're very right that it's not appropriate to even mention the chelator's name, but there is literature, and of course there is on our patient platform well described the effectiveness of each iron chelator drug on the different organs in the body. So please, and this is also, did you have to comment on anything, Professor Dusheiko, on this?
I think I would most certainly bow to the knowledge of someone treating iron in thalassemic patients on a day-to-day basis.
Yeah.
Thank you very much. And I think this is also, it gives me the opportunity to thank you both and express our deep gratefulness for your time and for your comprehensive information we've given to the patients. And this gives me the opportunity to pass on the message of Thalassemia International Federation for our patients and the doctors who treat patients, to urge the patients to follow our electronic patient platform. It is a very comprehensive electronic educational program that gives specific and very comprehensive and reliable information because reliability is one of the elements that we safeguard. We safeguard dearly at Thalassemia International Federation. It is reviewed by international experts, and the information we provide on our platforms is very regularly updated. So please, I urge everyone to go onto the platform, send us your questions. We are 24 hours at the service of the patients all over the world. So closing up, thanking you again, once again. Thank you for the participants who took part. Michael?
Just to say thank you from me as well. I hope the patients have actually got some of the main messages. And one of the main messages is monitoring is essential. It has to be regular. And adherence to proper chelation will probably save a lot of complications later on.
Thank you so much. Thank you.
Thank you. Thank you.
Thank you all. Stay well.
Stay well. Have a good day.
Bye.
Bye-bye.
Bye-bye.